Yes, good afternoon, good morning, good to everyone attending this session. I think since yesterday we've been talking about uh, technology to help for malaria elimination, and this session is about the sustainability of those tools and talking specifically about the future of digital tools for malaria elimination. I think we've seen DHIS2, for example, revolutionizing digitalization of health data in Africa recently and in most of the malaria endemic countries. And this has been a remarkable starting point for digital programs, but much more is still needed. And how do we sustain those efforts? This is what we'll be discussing about in this session. So to present mainly experiences from national and international partners with engaging stakeholders for sustained broader ICT for malaria programs. My name is Andre Troitieux, and I work for Medicine for Malaria Venture, where I mainly lead the chemoprevention interventions. So it's my pleasure to co-chair this session with Melinda Muri. Melinda is a senior program officer in the Global Policy and Advocacy Division at the Bill and Melinda Gates Foundation, and she manages a grant portfolio aiming at addressing cross-cutting global health R&D issues, as well as pandemic preparedness and response R&D, including vaccine manufacturing. So she was involved in overseeing the first proof of concept for the GSK ATSS malaria vaccine. And Melinda got her start in local production early in her career, and a fellow at USA. So I think I'll leave the floor to Melinda to introduce the panel, and then we can start getting deep into the discussion. Melinda?
Super, thank you, Andre, and it's quite a pleasure to be co-moderating the session with you, and thanks to MMB for putting this together. Many things have been discussed over the past day or so, and I think that this topic in front of us is one of the most important ones in the evolution of digital tools for malaria. So it's my privilege also to introduce the panelists today. And I've been enjoying interacting with them so far, and so I'm very excited about the session today and to hear more about what they have to say. So I'm just going to give a brief introduction to each of the panelists, just so you understand where they're coming from and their areas of focus, and then we'll get right into the questions. And also, I guess one other piece is there is a Q&A session or button that you can push on. So if you have questions that you'd like to make sure that we address, please put those in the Q&A and in the chat if you want to introduce yourself so that other people know who's in the session as an attendee. Please feel free to do that. You can also drop questions in the chat. So either way, and that's fine. I think everyone would like to make this as interactive as possible and make sure that everyone gets out of it what they came for. So to introduce our speakers, so Dr. Karen Cullender is the Senior Health Advisor and Chief of Digital Health and Information Systems in UNICEF's Health Program. So she's a Senior Health Advisor so let me go back. She's a co-founder and the UNICEF lead of the COVID-19 Digital Health Center of Excellence, which is a UNICEF-led effort to deliver technical assistance to national governments on the very topic of today, the sustainability and scalable deployment of digital health solutions. She has lived in Uganda, is currently, for quite a number of years, is currently an associate professor in the Department of Global Health at Karolinska Institute as well. So Dr. Meredith Stakem is also with us. She's a regional technical advisor for health with the Catholic Relief Services, who has also helped to organize this session. She supports malaria efforts in 4 countries, including 2 of them that have undertaken substantial digital work, and another that's in the process of exploring the digital technologies. we are going to hear from some of the work in those countries as well as Benin, and the takeaways from the key stakeholders that have been involved in those efforts. And then we also have Dr. Asa Hamid, who's a senior program officer and an M&E health system specialist at UNOPS Asia Regional Health Cluster. And so he has extensive experience across many different regions, and both within the United Nations and outside the United Nations. And we'll be bringing that breadth of experience, to our panel here today. So welcome to all the panelists, and appreciate your time that you're taking, and also look forward to delving into things. So we're going to start this out with a pretty general question, which is, how have you seen this area of digitization actually affecting malaria programs on the ground and in countries? And particularly if there are examples that you can bring that really highlight and bring a focus to some of these issues around sustainability and integrating these tools into the health systems. So let's start with, we'll go in reverse order. So we'll start with Asa, and if you could start us out with that question.
Good evening. I am in Vietnam. It's 10 o'clock in the evening, but it's really happy to participate with our colleagues, CRS colleagues. We work very closely with them with MMV. Very good question, actually. I've been supporting digitization of health information system here in Asia. I spent in the region nearly 10 years working with ministries of health, with WHO, with technical partners, PMI, and other partners and colleagues implementing malaria in the region to see how we could also deploy application, digital health, to support malaria elimination, particularly in surveillance. And when malaria moved to elimination, surveillance become itself is an action. You don't need the data just to count number, but you need the data to intervene the next day. And so over the last 5 years, I have seen really good leadership, good interest from government, from technical partners to really venture and introduce those applications. We work with University of Oslo, for example, to develop a very sophisticated health information system in Laos. I personally there that help Laos to detect outbreaks timely. Laos has, for example, history of detecting outbreaks very late, too late, and the epidemics was very high. Now, today, Laos could detect epidemics within weeks, respond within weeks. So these are very important. These are things that has been deployed at the community level, community health workers who are being supported by those efforts. But there is also upstream support from WHO technical officers who are there, making sure the guidelines are available. And the sustainability element is very important. These are integrated tools that owned by Ministry of Health, owned by the community health worker at the lower level, and those are also simplified tools. So these are very important to us having those capacities. I'm going to talk more, but this is just a quick start of how all those partners working together to deliver services, but also having those future perspective in terms of how to sustain those digital tools. Over.
Thank you for that. So Meredith, let's turn to you next.
Sure. Yeah, I would echo, I believe, what Asa has said, and I believe without a doubt that digitization is helping us have better, more efficient, and more impactful malaria programs. And health workers that I've spoken to really appreciate that they can see how, for example, an ITN or an SMC campaign is unfolding in real time and target their support and energy where it's needed. They've told me over and over again that it really helps to make supervision more effective. And I think digitization has also given the malaria community access to data that we've never had before or never had so quickly before. So for example, last year we worked to support a digital SMC campaign in Benin, and the campaign had very high coverage historically, but for the first time we were able to calculate the percentage of children that received all 4 of the cycles. And that number was a lot lower than what a lot of the stakeholders expected it to be. And it really generated an important conversation. And you sort of undermined that, you can't fix a problem that you don't know exists. And so this data really gave us the opportunity to see new challenges and to have conversations, and then hopefully eventually better target our interventions to solve those. And I think that by giving stakeholders, especially at that local level, local health districts, to national decision makers, to technical partners, to researchers, all of these people are benefiting from more complete, more reliable, more timely, and more user-friendly data, which is really pushing our malaria programs to understand what's working, to see what's not working, and to solve challenges, to really make evidence-based decisions and hold ourselves accountable for the best possible outcomes. And I think this will really be essential as we strive towards elimination. And certainly another benefit is that the benefits don't stop with malaria programs. This is data that can be leveraged for other health system needs. District health staff that I've spoken to, for example, are really excited to talk about how they can use better population data, more complete information to make decisions on other health needs. So we really shouldn't be underestimating, in my opinion, how digitizing malaria programs can really have benefits for malaria and much further beyond.
Super, and hopefully we can come back around to this question about the benefits to other programs as well, and any examples actually where that's been documented, but we'll come back to that part. So Karen, over to you.
Yeah, I just maybe, I fully agree with previous speakers, but maybe just to bring it down one level is, I think the use of routine health information data coming in from, say, community health workers, from health facilities on malaria cases, along with other illnesses, has given malaria there's much more visibility, not only to the health workers themselves, as well as to the community that needs the data. And we know from just not very long ago that most children who died of malaria were never recorded. Those deaths went completely unseen and unregistered. And just by the fact that, for example, tools have been developed for community health workers who track their communities, who register patients, who monitor illness, treatment, referrals, as well as deaths, has just given a lot more visibility to the problem. And also, I think it has given health workers more more putting the power into the hands of the health workers to understand the issues and also to be able to report problems upwards. And so I see this a lot in the digital platforms that have been developed for, in particular for community health workers, which is a space where I've been mostly involved. Especially when it's done in a comprehensive approach, not just separating out tools for malaria, but really making sure it's part of a PHC platform where malaria is part of it, and seeing how much health workers at that level feel empowered when they can not only document the case data, the ability to maybe not be able to do a rapid diagnostic test because they don't have any at stock, and be able to report that upwards and get a quick response. I think those are all aspects that strengthen the health system more broadly, increase motivation of health workers to do a better job, as well as providing visibility to the problem.
Andre, over to you.
Yes, great. Thank you. I think that is setting the scene. A lot of very positive comment or vision from all of you. But I believe that since this is a starting point introducing these tools, there have been some challenges definitely that you have encountered when implementing these tools. So can we maybe talk about those challenges that the system should consider when they're thinking of implementing these tools? And most of you mentioned about integration, you mentioned about these helping to tackle other health issues. And then how have the malaria tools being integrated into the overall health system, and how can the effort can be mutualized, can be shared in other program areas. Meredith?
Okay, sure. I think that's a really big question. Maybe I'll start with the first part on the challenges. We've heard a lot this week about different challenges, and I think just to be brief, I think one of the challenges is that we need to be thinking about digitization as short-term, mid-term, and long-term work. And really looking at how the local system needs capacity to evolve and grow as digitization also evolves and grows. It's not a static one-off thing. And so it really takes thinking through perhaps something along the lines of a transition plan or some kind of local capacity plan to think through how we can not just deploy a digital tool, but maintain a digital tool that will continue to grow and meet the evolving needs of the health system or the malaria activities in that country. And I can't say that I can point to a country or an example where we've really gotten this right. I think we're still trying to figure it out along with many others. But certainly it takes a mix of training, mentoring, accompaniment, and other technical support functions that go well beyond just technical support on the technology. There was a panelist yesterday who really spoke to, thinking about budgeting skills and project design skills as skills that those digitization teams will need. And that really resonated with me because I think the challenge is really keeping things up to date. For the second part of the question around the integration, we've done some really interesting work across different campaigns in Benin. Initially, we integrated within the malaria campaign space, so the ITANs with the SMC campaign. And then we went beyond to integrate with a neglected tropical disease campaign. And each campaign was building on the former campaign's data set and their tools and other approaches that have been used. And there were certainly some obvious advantages, like campaign workers becoming increasingly comfortable with the tools and with the digital approach in general, but it was also harder than I think we expected. And the experience convinced me that introducing an integrated approach is a real challenge that you shouldn't underestimate. Because even with the buy-in for integration, you're going to face inertia and resistance. And for many programs, it will be easier for them to maintain the status quo, since learning and adopting a new system takes time and mental energy. And the experience of integration comes with a certain amount of compromise and trust. So I heard a lot of stakeholders concerned about whether data from other sources was going to be of the quality that they needed or would meet their needs or goals, whether other people's data would make their campaigns look bad. So it really takes a high-level push and leadership for integration. And even where you have this, you're still going to face legitimate hurdles like budget cycles or limited flexibility to adjust timelines. We know SMC is very rigid in when it needs to happen. There's long-term challenges with supply chain. You have to think months, if not years out. So I think ultimately I would just say that the benefits of digitization are accruing at the systems level, and they really build over time. So it's super easy to undervalue the benefit to investment ratio. And I know there's been a lot of questions on that this week too, and calculating that cost benefit. I think it's really hard to do. And I think the same is true for integration. It's easy to focus on what you lose, but the population benefits from this better service and greater efficiency, and you need to get through that upfront additional time and energy to get to those benefits.
Thank you, Meredith. Thank you very much. I agree, it's a broad question, but I think, Karen, I don't know what you have to add about this.
Yeah, I'll speak about it a bit more from a digital health ecosystem perspective. And the way I look at this question is really how to think about it, how the malaria community, along with the HIV community and the maternal health community, all need to think about digital health solutions fitting into a wider health information system and digital health ecosystem. And I look at this as being almost three different layers, whereby what all these communities need, whether you work in malaria or something else, is the first layer being sort of shared services. This includes health workforce registries, health facility registries, logistics management information systems, health management information systems. And where we have gone wrong in the past, and much as a result of donor investments being very vertical, is that we don't invest in the shared services being useful for everyone. But we have seen countries like Madagascar where there's over 11 different DHIS2 instances, one for each disease. DHIS2 is designed to be an aggregate repository for all health data, and yet everyone keeps investing in a different instance for their disease. And we have to move away from this. This is where everyone has a responsibility to make sure that the system is comprehensive and cross-sectoral and works for everybody. And we can do this from the malaria community by just making sure that the right type of malaria data goes into the system and that it's useful in dashboards and visualization and sort of scorecards that benefit the malaria part of the Ministry of Health, etc. But we need to stop investing in siloed, fragmented, disease-specific approaches. And then the second layer is sort of where we also look at common digital health interventions, which is where the data is coming in from. And again, a lot of the data that we need is from routine health information system, whereby client data, patient data, stock data is coming in from routine systems. And again, we have to always look at this from the eyes of a health worker. And what kind of digital platform do they need? Do they really need a malaria-specific data collection platform for just malaria patients? We have seen community health workers being very demoralized by being provided with platforms that just collect data on some of the patients they treat, but not all the children that actually come to them. So even though an organization or investor or donor work in malaria, it's so important that the digital solutions that are designed for the health workers on the ground need to fit with their job descriptions and the curriculum and sort of the package of services that they deliver. And I think the third layer, where we see more perhaps unique solutions, is the digital health interventions that are designed with very specific functions that are needed for this particular disease. And here, I think for malaria, we do have a number of solutions that are quite specific to the malaria world, like the MDA solutions, IRS solutions, foci investigation solutions. And I think the malaria community has really contributed to this space by developing digital health interventions and solutions that can really be super useful for the response from when the data comes in. But what I would love to see now is, how do we expand those? How do we do foci investigation for COVID, for polio, for other diseases, so that the government can incorporate and internalize these types of very sort of function-specific digital interventions to other platforms, to other diseases and problems that they also need to battle with, because that's how they can become more sustained by a digital health strategy, a costed digital health plan, and not just have to be sort of disease specific. And I think we have come a long way. We see less and less of this fragmentation. We're not there yet. We still see a lot of specific digital solutions for malaria, as well as for other diseases, in particular for COVID-19. But I do think that the big job we have ahead of us is now to really try to make sure that we learn from each other, from each other's communities, and we're already seeing really exciting examples of how malaria tools are being repurposed for other diseases. And I really hope there's a call out to everyone that we need to collaborate more across sectors and collaborate more across donor organizations to make this happen.
Thank you, Karin. That's a really wide and detailed answer about this. I presume Asa will have something to add on this with his Asian experience.
Yes, Andrea, I think, let me say what we have done here. I mean, we know that when we come as UNOPS, not like UNICEF, we don't implement a health program. We support partners implementing health program. And when we come, we work with the malaria program that has a lot of vertical programs in terms of implementation, governance, and that also influence the system, how they design their health information system. But also working with WHO, working with PMI, working with Bill and Melinda Gates Foundation, with the Ministry of Health, bigger body than the malaria program, and everybody talk about integration. And we push on that direction. I think we invested a lot in building capacities for e-health. We have shown that actually e-health tools and apps could support integration. What the malaria needs, they could get it all and still can be within an operating system. Today, I'm sitting here in Vietnam, and I have a look actually this afternoon at the ECDS, that is basically the electronic reporting system for up to 38 communicable diseases, that malaria was just one of them. And the malaria person himself, who is responsible, told me actually when we started, we told the Ministry of Health, we want our health information system. We have the budget and we want to develop that health information system. And the Ministry of Health said, no, we want to have an integrated system. And he said, well, I was very happy they pushed us for the integrated system, and with the support from the Clinton Health Access and Telecom and the Ministry of Health, we were able to get everything. That system in Vietnam now able to report what just Karin have said. For science investigation in 24 hours, he was showing me what happened today. A response for those focus, that is basically malaria in small areas, for people who knows malaria, focus, and to respond within 7 weeks. And the system, you could go from one click to another, it gives you the details you want. If you want the patient, you get the patient. You want the species, you get the species you want. So everything the National Malaria Program they used to have vertically, now they have it here in integrated system. And he himself, at the malaria health information expert, have seen that how those available digital solutions are important. This is not easy because we have to demonstrate for them as technical partners that there is capacity building. There are tools, there are many technical partners like USAID who help you to think about what digital solution to use and how they work. Today, actually, Vietnam is moving from integrating only diseases, but actually integrating the national health insurance system. So when the patients use the insurance health system, the data doesn't go enter twice. You don't have to click to enter into the health insurance database, click and enter into the integrated disease. So they are solutions. And I think this is very important. The integration has to be supported, has to be always advocacy maintained. You have to show that how those digital tools, they do what we call them interoperability. That means they have the ability to speak, but also they would be able to meet the program's needs. So there should be no fear. Of course, behavior is an important aspect. People, want everything just fitting their needs. So also there must be strong political support, just like the example that's shown by the Vietnams. Today, we have a system also in Cambodia that collects all the malaria data, and Cambodians now working with the technical partners, WHO and others, to integrate it into the wider health information system. As malaria becoming smaller and there is other diseases coming, communicable diseases, there is COVID, then those tools, as Karin said, could be deployed. And that could happen from now if they are integrated. It can happen later on. And I think this is the important part of the political, technical, and also the continual behavior change communication for the health workers.
Thank you, Asa. Thank you. Go ahead, Melinda.
All right, thanks, Andre. I'm imagining that most of the attendees were having a similar experience to me of, as you were talking, remembering examples from different programs of where this integration didn't happen and the challenges to it. And there's actually a question in the Q&A section that I think really takes this, and so I hope what we can do now is sort of take it another level. Right, which is, and Meredith, I think you talked about this well of interoperability. I remember a technical wonk who I managed one time for a digital health project was like, interoperability is not about technology. It's like, that's the easy part. It's the interoperability of the people. And that's the hard part. And he's like, you can always fix the technology. And that just really stuck with me. And I think that that's been a theme that you all have touched on. And that's also, I think, the question that's in the chat. And so I'd like for us to take this even a step deeper and think about, and you can answer it how you want, but I think about two different levels of interaction. There's sort of the national level decision making that goes down to the community health worker. So there's sort of what the national government does, and some of you have talked to that. And then there's also the role, I think, Karen, you mentioned this, of the donors and the funders that are bringing in sort of that outside financing, but also that outside perspective. And we certainly know about one country I worked with was bifurcated. One donor had the top of the country, the other had two different health integrate, and so there's behavior, I think, on the part of donors that can also either enhance the kinds of things that you're talking about or make them very challenging. And so I wonder if we could, you don't have to speak to both of them, but if we could sort of between you all cover this, like the donor to the national level, but then that national government level down through to the community health worker. And whichever one of you wants to jump in on one of those, please go right ahead.
Sure, Melinda, I can start with that. I certainly had the opportunity to speak to stakeholders at various levels in Benin about this integration question, and it's interesting how different their perspectives are on whether integration makes sense and what the benefits are to them. So for example, community health workers, a lot of them are looking at, well, if they've been historically paid for days that they work on a campaign or days that they work on an activity, then they're concerned about losing out on revenue and resources, that integration is essentially a way to take days of work away from them. And I think that's a really valid concern and perspective, and something that's often not factored in. And then when you come to the level of like decision makers or health workers, they're concerned the quality could suffer, that they're going to have to compromise, they're going to lose out, or, that they're going to somehow come out looking worse. An example was like with our ITN campaigns, health workers, the frontline workers say, we have concerns that sometimes households inflate their numbers a little bit to qualify for additional nets. And then the SMC campaign, so still within the malaria space, they're like, well, if we use the denominator from the ITN campaign, then our coverage is going to look lower because we can't reach children that didn't exist. And so these concerns sort of about, what's in it for me, what's going to make me look good. And in situations where there's vertical funding and vertical programs, people, sort of assessing their value and the contribution by the size of the funding or the size of their reach, and they don't want to drive those numbers down. And I do think, as Karen said, that donors are sort of contributing to some of these challenges when they're focused on a single outcome. And I know a lot of donors say that they're very interested in health system strengthening, but when you look at the rhetoric around, okay, well, show us the cost effectiveness data for digitization, and that's actually really hard to do, because the benefits of digitization, if you're looking just at the campaign, I think they're always going to be undervalued. When you look at what's happening in terms of better decision making, higher impact, greater efficiency, that's really hard to calculate how that's spilling over. And so, sort of zooming out and taking that broader view about not how are we getting to a specific disease specific or activity specific outcome, but what is the overall benefit on health of the population, I think is what it's going to take for donors. So I think, you know, everybody's getting gains and losing something along the way, and sort of managing all those trade-offs and having honest conversations about where they exist is going to be really important as we sort of shift the dynamics on that and move towards integration.
Maybe I can come here. We work with the group of donors, the Regional Malaria Elimination Initiative for the Mekong, for the 5 countries that we are supporting, and not everything is shiny, but really have seen those donors we implement for Global Fund. I can't speak for them, but these are our major donors. But around the table, the Global Fund was able to bring Bill and Melinda Gates Foundation, PMI from USAID, national government, ADB, and all those are in the rooms. Health strengthening has been really a key interest in the discussion for malaria in the GMS country. And integration, and interestingly, although the room is full of malaria people, the national malaria programs and all those initiatives, PMI, these are all basically disease-specific initiatives. They are talking the same language of integration. Somehow, this was fascinating for me when I'm coming from a different region. So that was very, very important. And that was translated into action. For example, when we started digitizing the health information system in Myanmar, where I spent over 9 years just inside the country, we worked with UNICEF, with Karen, we worked with Access to Health Fund, which is multi-country donors from mainly Western donors, and the Global Fund. So it wasn't a one-man show. And then we had to work together with University of Oslo. Today, this individual country digitized system that is hoping and aiming for integration. Some of it is already integrated, as we have seen in Laos and in Cambodia, in Vietnam, is even linked regionally. So we have now a regional data sharing, health information sharing through support from University of Oslo. That is even moving towards a regional integration of data. Then you don't need to really invest a lot even to get the information in the border communities, people who move between those 2 borders. I think those regional initiatives, those donors being in the same room discussing country digitization issues is very important for pushing for integration. This was pre-COVID. After COVID, I think this is another challenge, because with the push for having those individual COVID certification, COVID system, we have seen again a divergence where the national program quickly set up a vertical program for COVID. And I think the dialogue needs to continue. Very important, I think, is the data use to be as not, I'm talking about data use like why we use data, but also is part of the dialogue for pushing for integration. As Karin said, if the data entry is happening at the same person at the healthcare facility who does for malaria, for HIV, for other data, so basically we have to reduce for him or her the transaction of entering multiple data, but also the data use at the upper level. Nobody wants to look for sophisticated malaria reports, sophisticated HIV report. They want something that is integrated, fancy, and also usable. So I think the use should also be used the data use should be used as an argument for why we integrate.
If I might come in and take the first part of your question, which is the donor to national level, because this is something that we have invested a lot of time in over the last 2 years to try to improve the situation. You know, in 2018, a lot of donors came together and launched something called the Digital Health Investment Principles, which are endorsed by pretty much every donor in this space, with an idea that these principles are meant to harmonize and align investments, international strategies for digital health. Unfortunately, they haven't really fully been operationalized. We started off having sort of ad hoc calls across our donor organizations, but one thing that COVID brought on, a positive aspect to this, is that it really enforced donor coordination in the space of COVID-19 solutions. And actually, for the last 2 years, we're meeting on a weekly basis across all donor organizations, including Gates Foundation, CDC, Global Fund, Gavi, et cetera, to really try to better coordinate investments at country level to avoid this fragmentation that keep happening. And one thing that came out again from COVID that is hopefully being extended beyond COVID and now being applied to more broader health system problem is the Digital Health Center of Excellence that we established in particular to try to coordinate investments around the COVID vaccine distribution, because we knew even before the vaccine was in place, we knew that this was going to cause chaos at country level when everyone comes in with their favorite tool and want to deploy this for monitoring COVID vaccine distribution. So through the Digital Health Center of Excellence that UNICEF and WHO are co-leading, also call it the DICE, the primary objective is to try to better coordinate investments based on what the countries are asking for and what the national governments want to see in place, instead of trying to come, with a solution that's been sort of not introduced before. And one of the things we always recommend when we have a country now asking for support is, what do you have that can be repurposed? And through some work that Digital Square has done, as well as what UNICEF supported, is a landscaping. So we have 50 countries or so now, where we have looked at all the different solutions that they already use, and to be able to identify opportunities for expanding these beyond what their primary use case was, so that we don't start from scratch. And this has really helped donors to sort of not come with suggestions or not fund projects that come with a solution that isn't already in the country. And we really hope that through this technical assistance that DICE provides, is going to help the governments to take the decisions themselves, informed decisions on which solution is the most suitable for their context. And what we're also trying to do is to not look at DHIS2 as the one and only solution, because DHIS2 can do many things, but it can't do everything. And the answer there is in the interoperability, like which other solutions do you need that can be interoperable with DHIS2? And so through DICE, we're really encouraging partners at country level to also discuss amongst each other, build on what others have started, not come and start from scratch again, because we know that's not going to be sustainable. But a lot of that lies on the donor's responsibility to not fund those projects that suggest coming in with a new tool or a new solution where it isn't necessarily needed, but rather support the governments to have the power and information to be able to come up with a strategy that can sort of be costed in the long term, that donors can feed into, and which can be sustainable. So we're at the starting point. We're actually celebrating our first birthday for the DICE, Digital Health Center of Excellence, tomorrow. So it's just starting, but we see this as a movement which seems to be resonating with many out there, and who also believes in that this is the way to work. But we just need a mechanism to help us do it better.
Thank you all for those perspectives, because it's actually great to hear the progress that's being made. And it sounds like both in terms of getting the people together, but then also some of the tools that would empower national governments to be able to set the agenda than for others to, more fall in line with. So thank you for that question and those answers that I think are really insightful and also promising. It's very good to hear about some good examples where this is happening. So Andre, over to you.
Yeah, thank you, Melinda. Thank you all. Really, this is very, very insightful, very insightful about digitization. I'm discovering a lot of things. I'm mainly working on SMC, and now I'm kind of discovering what is being done outside of SMC. You may not know, but integration has been pronounced here in the last 30 minutes about 50 times. So integration is coming up as the way to go, and something that Karin just said is that GHIS2 is not the magic bullet. It can do a lot, but not all. So interoperability, it's looking like another point to stress on. But what do you believe is the future of ICTs for malaria elimination? And how do you think we get there? Because apparently we all know what to do, but why is it not done? So how to get there? Meredith?
Okay, sure. I think at the risk of saying integration a few more times, I think the future is locally owned and integrated digitization efforts. We've heard a lot today from a lot of perspectives. It doesn't make sense for different disease programs to have different tools and technologies. It's too much of a burden on frontline workers to learn them, and it's not reasonable for central governments to manage them. So to get to a locally owned and integrated model, I think we need to ensure that we have local ownership for digitization even before it starts, and that we work together with these local owners and partners to design tools and approaches that align with the health system. And that's easily said. But I want to focus maybe on an aspect that I think is really important in getting us there. And I think that, to me, that's the investment in digital literacy and data use capacity across the health workforce. Because the benefits of digitization are in the data. But the data is only useful if it's used effectively. So when we equip and empower frontline workers and national decision makers to really analyze and deploy that data to drive their own decisions and to reap the efficiencies, they're going to see the benefits. And if they see the benefits, I think they're going to be clamoring for it. So to me, this is how we get to local ownership, is helping those health stakeholders use the data that's coming out of that. So I think if we invest in data use skills, local ownership will follow naturally, and we're going to end up in a situation where we have locally owned integrated digitization efforts.
Yeah, thank you. I don't know, Karin, yes, go ahead.
Yeah, I just fully agree with that. And just to point out, though, that having an integrated health information systems, it requires a significant amount of time and effort to develop. And we have a really good example from Tanzania, where they really made an investment at the government level to try to, to design an integrated HIS. And they now have a system that's there's data exchange between 15 different information systems, and it has really improved availability of data, quality of data, and it's leading to significant time savings. But it took, a lot of time and effort, and the long-term benefits of this will be, substantial. But it isn't something that we should think it's a quick and easy fix, but it's where we sort of need to be. And in the meantime, I think countries that still have an immediate need and where there isn't a longer term plan for an integrated health information system, we need to work with solutions that can, in the future, fit into this ecosystem. So we make sure we work with global good solutions, open source solutions that follow standards, so that that integration doesn't have to be painful and costly and difficult. And that's the beauty of having a number of global goods out there, is that they are global goods for a reason, is that they fulfill those standards that make them interoperable. So that's one thing I would really, again, emphasize, that we use the word integration a lot, but integration isn't actually that easy. If we look at a very simple example of health facility lists, like all solutions need to have administrative data. We need to know where the cases are reporting from and where action is needed. Many countries don't have a master facility registry. They don't have one sort of true, one set of true data on every functional health facility in the country with geolocation. And as a result, every digital solution that's being set up creates its own health facility registry as part of that solution, using different health facility names that don't match. And it's a very simple example where data integration completely fails because we don't have one shared service. And again, this is where it's so important that anyone working in a disease-specific area should ideally come together and invest in a shared service that isn't just malaria facilities that provide malaria services or facilities that provide HIV service. We need one true source of information. It also goes for health worker registries. We don't need a health workforce registries for malaria workers. We need one for all health workers that can then feed into the different digital systems. And that's where I want to emphasize the need of investing in these shared services that benefit all programs, because we can talk about integration as much as we want, but it won't happen until we speak the same language using the same master list of information.
Good. Thank you.
I would like to add my voice to what just Karin have said. And I think the future for digitizing malaria and even how malaria will continue to benefit from those digital solutions also lies on the continued capacity building. As I said, we have, as she mentioned, we have invested a lot. We have to continue to invest in building capacity. And I just want to not to leave this forum without mentioning community health system strengthening. We know that as malaria goes lower and lower and lower, it goes even further into the rural areas, into the forest. And the front health workers change from the health worker that we know with literacy to community health workers. And we have been working with over 30,000 community health workers. I would say now more than 30% of them use digital solution to report malaria. This is fantastic news, using tablet and a smartphone with support of Save the Children. In Myanmar, we started that pilot. In Cambodia, all the health workers, the community actually, because using those platforms. So we have to sustain them, continue training, continuous SOPs, data quality insurance, improving connectivity, and no matter how, the costs are going to be very low. These are people in their community receiving only very little incentive. And I think the future is continuing to build capacities on those community health workers and continue to push for integration.
Thank you, Asa. I think we have a few minutes to go, and I think there are questions in the chat. Most of them have been addressed. Speaking of integration and interoperability, I think we discussed that. We touched about it, and there is a question about often programs are supported by partners for a limited number of years. And I think, Karin, Meredith, you've touched a bit about this. Years, platforms come and go. How do you get the platforms to be owned by Ministry of Health, not just technically, but also technologically? I don't know if one wants to get that question. Yes, Meredith?
Sure, maybe just to add a piece to this, I think it's an excellent question. Something that we haven't talked about yet is that, this comes back first, perhaps to a health system strengthening approach and recognizing that ministries of health may need to be structurally different or funded in a different way to have that capacity that they need to support these systems and to stay at the forefront of owning them. But some countries even are exploring, is the Ministry of Health the right place for this, or does it make sense to have a ministry of digital technology or something like that that could support digitization efforts even across different sectors? So health, education, customs and border control. So, I think this really comes down to much higher level conversations and advocacy with governments about how they can drive technology forward.
Thank you. Thank you. Any additional comment? Melinda?
Well, I think that addresses the questions that were in the chat, and I realize we're coming up on the 5-minute mark. And so I thought maybe the way that we could end this is for each of you to just say, like, what is it that you're excited about? Like, if you look over either the next year or the next 10 years, what is it that like gives you hope about this issue of sustainability, or that you're excited about the opportunities for? So let's see, we'll start with Asa, you first.
I'm excited because as we getting near to eliminating malaria, that the last malaria case will be hanging somewhere in a mobile phone somewhere, and I'm running to get the internet connected, like in some places. And please get the scratch card and get that case, because that's the last case to eliminate. So I'm really excited, and I'm saying this because we've been seeing people with mobile phone in the forest reporting to us some cases that before it used to reach us in 3 months, 4 months. So I'm really excited that the final push will come from technology while we are working eliminating malaria.
That is an inspiring vision, to be sure. So thank you for that. Karen, let's go to you next.
I think what excites me at the moment is to see how sort of COVID-19 has transformed a lot of the ways we do digital across all programs. And not only do we made a huge leap in the world in realizing how important it is to have data and how we can actually utilize data in a more effective way. It has also shown how important it is to have strong health systems, and how going forward, we need to build more resilient health systems. And a resilient health system is a health system that is evidence-based, driven by data, and that detects these, disasters in good time. So what I'm really excited about, in particular in this space we're talking about today, is how actually over the last 2 years, a lot of the really good tools that existed for malaria have now been applied successfully across other disease areas. And I think this addresses one of the questions in the chat around the importance of mapping and geolocation of not just individuals, but of health facilities, of households, and using these micro mapping solutions to better deliver services. It's a hugely important intervention for identifying children who have never been immunized. It is becoming an important intervention for COVID-19. It is obviously a really important intervention to identify households that need to be sprayed. So I think it's been really exciting to see how what used to be very siloed interventions for specific diseases is now sort of opening up and becoming broader, and we are applying the knowledge more broadly so that these health systems that we're trying to support can benefit more broadly from these innovations that have come out from the different disease communities.
Super, thank you very much for that. And Meredith, over to you.
Sure, I think for me, what I'm excited about is the potential to have data and knowledge that will allow us to better deploy the tools and resources we already have in our toolbox against malaria. I think people often get excited about the latest innovations, but we've been held back for a long time by not being able to effectively deploy everything that we have. And I think digitization is giving us data and showing us where those gaps are in delivery, and really helping close those gaps with the tools we have and bring better health outcomes to the people we're most looking to serve. As Isa said, let's move towards that last malaria case.
Thank you so much to the panelists. I've enjoyed hearing from you and the progress that's being made. And also, I honestly, in this area, it is easy to see the challenges and the where we're not integrating, but it's been really, really great to hear of the examples where it is changing and things are happening differently, and the optimism of the image of sort of that last case, and the digital technologies are going to play a role in bringing us there. And so thank you to each of the panelists and to MMV and Andre for being your co-moderator for the session. And I believe that we are at the end of the session. So thank you all for your participation.